Okay, good afternoon, everybody. Can everybody hear me? The mic's working? Yeah, sounds like it is. Okay, great. My name is Ed Hurwitz. I am one of the co-leads of the LHS Collaboratory. Dr. Friedman Chuck is out of town. And I'm so pleased to see everybody here today. Thanks for coming on this freezing cold day. And our title of our presentation today is Preparing Clinicians for Artificial Intelligence in Healthcare. So again, thanks for joining us today. I want everybody to know that today's event is being recorded, and the slides and the recording will be available on the LHS Collaboratory website archive. We're going to have a panel discussion today and an audience Q&A session at the end of today's event. So after all our speakers, panel's going to sit down, and then we'll start to take questions from there. So we have a really wonderful lineup of speakers today. Dr. Cornelius James is going to talk about preparing clinicians for artificial intelligence in healthcare. And then we'll have commentary from Ben Lee, who is an MD PhD student, and from Virginia Sheffield, who is a clinical assistant professor at the University of Michigan Medical School. And then we'll have commentary from Dr. Jim Woolliscroft, former dean of the Michigan Medical School. And that is our lineup, and we're looking forward to a wonderful presentation. So let me introduce the first speaker. So Dr. Cornelius James. Cornelius is a clinical assistant professor in the Department of Internal Medicine and Pediatrics and Learning Health Sciences, all those places, at the University of Michigan. He is a primary care physician practicing as a general internist and a general pediatrician. Dr. James has served in many educational roles across the continuum of medical education. He also serves on local and national medical education committees. In multiple years, Dr. James has been identified as one of the top teachers in the Department of Internal Medicine. In addition, in 2022, he received the preclinical Kaiser Permanent Excellence in Teaching Award, which is the most prestigious teaching award given by the U of M Medical School. Dr. James has completed the American Medical Association Health Systems Science Scholars Program and is one of the 10 inaugural 2021 National Academy of Medicine Scholars in Diagnostic Excellence. As an NAM scholar, he began working on the data-augmented, technology-assisted medical decision-making, known as Data MD, curriculum. The Data MD curriculum is designed to teach healthcare professionals to use artificial intelligence and machine learning in their diagnostic decision-making. Dr. James is also leading the Data MD as they develop a web-based AI ML curriculum for the AMA. He's published articles in JAMA, the Annals of Internal Medicine, Academic Medicine, the Journal of Geriatric Internal Medicine, Cell Reports, and more. He's interested in curriculum development and teaching learners to provide evidence-based, data-driven, equitable, patient-centered care. His research interests include clinical reasoning, implementation of AI/ML curricula across the continuum of medical education, and implementation of digital tools into clinical practice. Dr. Cornelius James.
Presenter. Okay, well, super excited to be here this afternoon. And I really appreciate the introduction from Dr. Hurwitz, and I appreciate Dr. Friedman and Dr. Walji inviting me to come and speak to you about this topic. So I don't have any disclosures. I thought it'd be good for us to start with a case to kind of kick things off. So imagine that you're a pathologist at an academic health center, and that academic health center has recently implemented a artificial intelligence system called Page Prostate. And this algorithm has been designed to identify suspicious lesions on a prostate or digital images of the prostate or prostate biopsy images. So at the top of your list of high priority images is Mr. Johnson's images. And he's a 62-year-old who's had a weak urine stream, Also had some nocturia and microscopic hematuria. Nocturia being waking up in the middle of the night to urinate, microscopic hematuria meaning blood in the urine that isn't easily detectable with the naked eye. Recently, I had a prostate-specific antigen, or a PSA, as many of us know it, of 8.3, and that's significantly higher than what it was about a year ago. So urologist, he was sent to a urologist. Urologist did a digital rectal exam where they placed the finger into the rectum, evaluated the prostate to determine whether or not it was enlarged or had any abnormal lesions or abnormalities when it comes to any things that's suspicious for cancer. But they noticed that there was an enlarged prostate, but no discrete lesions. So they did do a biopsy because part of the reason they did that prostate biopsy was because Mr. Johnson's dad actually has a history of prostate cancer that was diagnosed at 57 years of age. So because of that, again, did the biopsy, and the AI system identified an area that was highly suspicious for prostate cancer. However, the pathologist will say that that's you believe that the sample is negative for prostate cancer. So I'm going to ask you, what would you do in this situation if you were faced with this? And feel free to speak up or yell out, it's totally fine. What would you do in this particular situation? So in sum, AI algorithms saying, this looks like this person has cancer, clinicians saying, I don't think this has cancer, or this prostate, or this sample has cancer. What would you do? There's no correct answer, so do not feel nervous about yelling things out.
So Cornelius, we have an idea of the accuracy of pathologists.
Right.
Over many, many years. We have no idea of the accuracy of AI.
Okay, thank you. I think I heard something else. Thank you, Dr. Hurwitz. Did anyone else have an idea or a thought? Second opinion. All right, I've heard that one before. Thank you, Mary. Anyone else? Rebiopsy, okay. All right, any other thoughts?
I'd call my friend Dr. James and ask him.
Okay. All right, thank you, Dr. Sheffield. Okay, I appreciate the confidence. All right, so maybe you asked ChatGPT. No? No, I see some head shaking. No, I wouldn't do that. And you put a simple question in there that says, can AI accurately diagnose prostate cancer? And it says, AI has shown some promising results, right? And numerous studies and research projects have concluded or have been conducted to evaluate the performance of AI in this particular domain. Several AI algorithms specifically have shown impressive results. However, it's important to note that it should not replace pathologists. You check specifically to see if Page Prostate, which is the system that's been implemented into your system, can accurately diagnose prostate cancer. And what it says is, I don't have any information on Page Prostate because I was trained, this model, as many I'm sure you are aware of, was trained on data up until September of 2022. So not very helpful, potentially. But let's say you notice this, that you do see some pretty strong or solid evidence suggesting, you look at it yourself, you go to the primary literature, and you see some strong evidence suggesting that Page Prostate has demonstrated pretty solid performance. What if you notice this? The FDA has cleared Page Prostate for marketing, okay? Would that in any way change what you would do? Or has anyone changed or kind of reconsidered what they would do in that situation, given that you now see evidence and you also see FDA clearance? Would that change anything that you would do? Does it give you more confidence? Less confidence? Anyone? More? I'm hearing more. Okay, more, thank you. Anyone else? All right.
It makes you more nervous.
It makes you more nervous. Okay, all right.
With rebiopsy.
So that situation, thank you, Dr. Hurwitz, that situation is certainly hypothetical, but Page Prostate is real. This situation is real as well. So these are all of the models that are currently either running in the background or actively implemented or deployed at Michigan Medicine. So this is something, while it may not be the same situation as Page Prostate, this is something that our learners, residents and attendings are facing. For example, the epic sepsis model is something that clinicians are coming in contact with. So this is something that we should be kind of considering or thinking about. Another question that I'm asking you now is, what skills, given that case or that scenario, what skills will physicians of the future need if they're going to deliver competent, data-driven, evidence-based, compassionate care. So my objectives this afternoon are to basically summarize the current state of artificial intelligence in medical education. I'm also hoping to provide a vision for what I think it should or could look like in medical education. And then I also want to summarize a few specific initiatives that I've had the privilege of working on and that others are working on when it comes to AI in medical education. And finally, I clearly do not have all of the answers to these questions, so I'm hoping that I can stimulate some thought and some dialogue around artificial intelligence in medical education. So this is an issue. As you all know, we are seeing increasing amounts of data, right? Data that maybe not impacting directly the decisions that we're making, but they should be, right? But our human brains are only capable of holding on to and or analyzing or synthesizing a small amount of information relative to the information that's out there. So the question is, where can we get some help? So in November of 2022, we saw a pretty significant inflection point. Now, I've had the privilege of working on some of these things since before November of 2022, but I would say in November of 2022, there was a pretty big inflection point in medical education when it comes to AI. In some respects, ChatGPT became synonymous with AI in healthcare, right? Because we were just starting to really learn about it. So we paid a lot of attention when we saw, okay, ChatGPT can potentially pass the bar exam. And then there was even more attention when we said it's passing USMLE style question, or it's doing well on USMLE style questions. ChatGPT 3.5 performed well, ChatGPT 4 performed even better. And then, there have been some failures. So for example, here when it comes to the gastroenterology board exam or self-assessment test, didn't perform as well. And the same is true for nephrology type board questions, didn't perform as well there. So we also know that there's medical AI or large language models out there that are specifically intended for clinical questions. So here's one, this MedPalm from Google, which you can see MedPalm 2 performing significantly better than ChatGPT 3.5. And then here we even have open access large language models out there like Metatron, right? And then we also know that organizations like the University of Michigan have developed their own large language models, right? To kind of provide a little bit more confidence when it comes to the privacy piece. So these are all things that are coming at our learners. And the question is, are our learners, I'll ask a question knowing some of the people that we have in here, are our learners prepared to structure or formulate a clinical question in ChatGPT or in a large language model that's well built, well structured, kind of similar to the way that we'll structure a PICO question? Are they ready to engage with those types of technologies in a way that's going to be effective? Are they ready to appraise and analyze and or apply the outputs of a large language model like a Metatron or a MedPalm, right? I often draw the comparison between UpToDate and these large language models. And that UpToDate at one point, we weren't super confident in it, right? We didn't really consider it to be an evidence-based resource, but as time went along, UpToDate, I probably check it like 2 or 3 times a day in my clinical practice. I have a feeling that we're gonna see the same thing here. Now the question becomes, how do we encourage or instruct our learners to engage with these types of technologies? So this was a relatively recent New England Journal of Medicine poll. It looked at the top 2 things that we as medical educators should be preparing our learners for to be successful in clinical practice. You can see here number 2, data science, including artificial intelligence and machine learning. All right, so recognizing that it's pretty important. Unfortunately, this is the current state of artificial intelligence and machine learning related material in medical education. What you're largely seeing are electives, online offerings, some workshops, some certificate programs, and interest groups. All right? That is not going to be enough. We need to do more. So this was a model that many of us are likely familiar with, the biomedical model introduced by Abraham Flexner in 1910. Certainly there were some strengths associated with this model. I think it was great. It introduced this biomedical model, right, back in 1910. And I'm going to also just note that Abraham Flexner was not a physician, right? And he took a lot of what he recommended from German medical schools. He looked at that as kind of being the standard, right? So 1910, Flexner introduced this. It was a huge paradigm shift in medical education to the extent that many medical schools closed as a result of this report, unfortunately including historically black colleges and universities, which was not great because there were not many back then to begin with, right? But there were some good things about this model. So paradigm shift. And I look at, I'm biased, I direct the evidence-based medicine curriculum here at the university. I look at evidence-based medicine as a pretty big paradigm shift as well. If you look at the BMJ, relatively recently, they identified it as evidence-based medicine as number 6 out of 15 when it comes to medical innovations in the 1800s, right? So I look at that as a pretty big paradigm shift as well. Because it did change. So Abraham Flexner's model or report, paradigm shift, evidence-based medicine, really, really important too, because it did lead to us saying, okay, we've got to teach our learners to acquire, appraise, apply the medical literature. I truly believe that artificial intelligence and machine learning is that next paradigm shift, where it's going to change everything. It's going to change the way we educate and teach our learners, and it's also going to change the way we practice medicine. That's my belief. So I've proposed this biotechnomedical model, okay? A little bit different. But the point there is to just kind of emphasize the importance of technology in our patients' everyday lives. Can I ask everyone to just, if you have a smartphone, raise your hand. Okay, if you have a smartwatch, raise your hand. Smart speaker? Now, I think everyone raised their hand to something, right? So in your pocket or on your wrist or in your home is something that can monitor, or it contains potential biometric data, right? So that's how engaged, that's how connected we are to technology. One of my mentors, Bob Wachter, he actually stated jokingly at one point that, yeah, eventually we're going to have smart toilets where it's going to analyze what goes into the toilet and let us know if there's any concerns. I looked recently, that's actually happening right now, right? He previously said that jokingly, but now it's a reality, okay? As clinicians, we're going to be acquiring that data. We need to figure out how that's going to be presented to us, how we analyze it, how we synthesize it, how we apply it to our patient care. And that's where I'm thinking that approaching this from a biotechnomedical model as opposed to the prior or previously implemented or recommended biomedical model is going to be most important here. So that means we're going to have to start viewing AI as a fundamental tool of medical education or medicine or healthcare, where it's as important, or we're teaching it the same way that we're teaching the history, the physical exam, the same way that we're teaching to interpret lab results, x-rays, EKGs, et cetera. You need to look at it as a fundamental tool of medicine. So I don't expect that change is going to happen overnight. There's no way that many of the things that I'm saying are going to happen overnight. So I anticipate that over the next 1 to 2 years, we'll see content related to AI incorporated into specific curricula that have overlapping content. For example, health system sciences. We have clinical reasoning here at the University of Michigan. It's referred to as chief concerns. Evidence-based medicine, and then doctoring. And these are just some of the concepts that I've kind of thought about. I have not done a full concept map yet, but some of the concepts that I've thought about that are kind of related to these specific disciplines. I specifically want to point out here, and this is the University of, I adapted or kind of adapted this from other evidence-based medicine cycles, but this is the one that we use here at Michigan, and you can potentially see some of the overlap or how relevant some of these concepts are to AI, meaning acquiring some of the AI literature and or outputs, applying those outputs and or that literature in clinical care. So this is our 4-year curriculum here at Michigan. My expectation is that even before people get here to Michigan, they're gonna have a lot of experience when it comes to AI. I really do think that relative to where we are, the students that we are admitting at this time are going to be very different compared to the students that we'll be admitting in the near future. So, and then even after, we talk about the master adaptive learner, the things that we're even teaching our learners now, and this is where, we talk about moving from, information retention and or regurgitation to information managers. Teaching our students to be adaptive is going to be super important because, as we all know, things related to AI and healthcare in general are going to continue to evolve. So that master adaptive learner concept that's relatively new is going to also be important. This is our current state. This is where we are when it comes to, this is our first block. We often refer to the clinical sciences, basic sciences, and health system science as kind of the pillars of medical education, right? This is our current state. I'm anticipating that AI is going to change the way that we teach each of these domains, the way that we practice in each of these domains. And my hope is that eventually, when we talk about these basic sciences or basic things that are taught within the curriculum, data sciences plays a pretty big part or pretty big role in that as well. And I'll talk a little bit more about that in just a little bit. So this leads us to kind of think about who are medical educators going to be. Is it going to just be the clinician and the pharmacologist and the pathologist, et cetera? Or do we have to rethink or reconsider who, given where AI is headed? I'll tell you, I'm going to show you a slide in the very near future. We've developed curricula, and it would have been impossible for us to have developed that curricula without some of these individuals on our team. And I do not believe that it's going to be possible, at least early on, for us to teach this content without some of these individuals. Okay? So maybe we can look at a biotechnomedical model example. So this is block 6 of the University of Michigan curriculum, where you can see we're learning foundations of medicine, infectious diseases, hematology, immunology. Perhaps we start to incorporate something related to predictive models in there, where we're seeing some integration, and we look at those courses that I mentioned earlier, and we can see some potential examples of how we can apply or look at the epic sepsis model in relation to those other things that we are in relation to those other subjects. So finding kind of overlap there. And I'm hoping that 10 years from now, these are some of the the focus will move away from information recall. Again, there's just simple retention and the administrative burdens, and that we can move to allowing our students to use more of their creative and or effective skills in their clinical practice. So I'm not anticipating that every clinician is going to be a computer programmer, that they're going to be an engineer or anything like that. But very similar to evidence-based medicine, not expecting that everyone's going to do a randomized controlled trial or a mixed method study or a secondary data analysis. But the expectation is that every Michigan student, at least as the director of the EBM curriculum at Michigan, every student can appraise a randomized controlled trial, is my hope. Every student can appraise a cohort study. And ultimately, every student will be able to appraise and or apply the AI ML literature and or outputs from AI ML. That's what the hope is, not that everyone is going to be a developer. So there have been some that have developed competencies. Bonnie Miller, I've had the privilege of working with her and her team. And this is a great start when it comes to some competencies for AI in health professions education. But I think we're going to have to think about these a little bit more. And some have also provided their input with some qualitative interviews with experts on how we should begin to instruct or teach our learners this content. So I mentioned earlier data science is important. One of the concerns that I've had, I think AI is certainly, it warrants or it has earned a lot of attention. But there are other concepts here that I just get a little bit concerned about that we have not given enough attention. And I'm thinking along the lines of data science in general, right? That's a bit broader. There's overlap between AI, data science. The same is true for digital health. That is, I'm concerned that our students could potentially enter the workforce without a real understanding of what digital health is, how to apply it, how to use it, and then ultimately kind of reaching what I consider to be the apex, which is more precise medicine or precision health. I think we need to start to think about how these things kind of interact, how they integrate with the ultimate goal of precision health. So another goal is this triadic. Colleagues and I had an opportunity to write this paper for AHRQ, where we talked about this triadic patient-clinician AI relationship. This is basically, when I'm kind of envisioning things, this is what I'm trying to kind of move toward when it comes to our learners and how they're interacting with both AI and how they're interacting with patients and vice versa, and kind of in that circle that you see up there, how they're all kind of interacting ultimately for the benefit of the patient. So how do we get there? So Dr. Hurwitz mentioned the data-augmented technology-assisted medical decision-making curriculum. That's something that I had the privilege of beginning to work on with colleagues here and some around the country. And the mission for that team is to develop, implement, and disseminate innovative healthcare, AI, ML curricula that serve as a foundation to educators so that they can develop their own curriculum. Not a one-size-fits-all approach. I understand that the University of Michigan is very different from OUWB or Wayne State. So to just provide that foundation so that they can start to think about what are some of the things that we need to begin teaching our students. And the same is true for residency programs as well. Not anticipating that this will be a one-size-fits-all, but to at least start to provide some foundation or an introduction to some of the concepts that that students and house officers should be learning. So this is our team here. Again, I mentioned that it is a multidisciplinary, it's an interprofessional team. You have lawyers, you have computer scientists, you have engineers, you have researchers, you have librarians, clinicians, educators. This team came together on just about a monthly basis. You have students, Ben, and you have house officers as well. Really important to get their input on this as well. And this team came together about monthly, and we're still interacting, and you've probably seen us together in other venues, but this team has been super helpful and instrumental to some of the success that we've had thus far. So it all started with the National Academy of Medicine. I was a NAM Scholar in Diagnostic Excellence where I began working on this project. And in this 2015 NAM report, they emphasized the importance of education. Education, not only when it comes to the diagnostic process, but also making sure that we are incorporating technology or health information technology or looking at the role that that plays in the diagnostic process. I think AI and ML are included or should be included, are included in that. So the frameworks that we considered as we developed our curriculum were basically based on this NAM diagnostic process. And we focused here on this information integration and interpretation, gathering and working diagnosis. We focused a lot on that because I think that's very highly relevant to the EBM. So we kind of used those two processes to develop our curriculum. Okay, it was very much focused on that. So what we've done is we've developed 4 web-based modules working with the Center for Academic Innovation here at the University of Michigan, using a Bayesian approach, kind of allowing students to appreciate the overlaps when it comes to AI and ML. Okay, yeah, so sensitivity, specificity, there's some relationship between area under the curve and AI and ML and evidence-based medicine. So kind of those concepts that they've become familiar with, helping them to kind of see, okay, this may not be as bad as you think it is. It's applying some context, or some similar concepts, but just in a little bit, in a different way. That curriculum is scheduled to launch in April of 2024. Andrew Wong, who's a current chief resident here at Michigan, he took that curriculum and he basically brought it in person to the internal medicine residency program. And he did 2 sessions, actually 4 sessions in 2 days, and he took our learning objectives and he took much of the content that was developed by those experts that you saw up there, brought it in person, and the residents responded very well to this. We noticed statistically significant differences pre-test, post-test when it comes to their attitudes related to AI and ML and when it came to their knowledge of AI and ML. So I think this is great. Andrew's currently working on a manuscript related to this, and he's supposed to submit it pretty soon to academic medicine. And then the AMA, or the American Medical Association curriculum, you may have seen or heard about this. We've released 2 modules thus far, with a plan to release a total of 7 modules related to AI and ML in healthcare. The next module will be released in February 7th, I believe. And this is going to be a bit broader in scope relative to the Data MD curriculum that I mentioned earlier. I'm also working with a group with Winston Leal at the University of Houston on this AIM PC, Artificial Intelligence in Primary Care. I'm very excited about this curriculum because it's going to not only include kind of that foundational content for medical students and residents, but you can also imagine for the community primary care physician or community physician that's not in an academic environment, this can be really intimidating. It's intimidating enough for those of us in an academic environment, but you take that community physician in a non-academic environment, it can be pretty intimidating. So I'm excited about these brief video series, or this brief video series that we're doing for this curriculum that's specifically targeted to those community physicians that are in non-academic settings. This is going to be released in 2025. There have been interprofessional efforts. Kim Lomas at the AMA published this paper related to artificial intelligence in health professions education. That led to a workshop through the National Academy of Engineering, Sciences, and Medicine. That was a hybrid workshop, brought people from all over the country together. to talk about what we should be thinking about in teaching and learning AI, when it comes to teaching and learning AI, or using AI for teaching and learning. So multidisciplinary workshop, very successful, and it was very much based off of this box from that paper from Kim Lomas that I mentioned earlier. There are workshop proceedings from this, so I would encourage you, if you're interested in looking a little bit more, that is, you can obtain that free of charge on the National Academy of Medicine website. I've also been invited recently to this International Advisory Committee for Artificial Intelligence, and the goal there is to basically provide advice or advise on a global scale medical education initiatives around artificial intelligence. So that's another thing that's going on that I'm excited about. And I also want to just point out that this will not be without challenges or difficulties. I think we're going to have to think hard and closely, or think carefully about some facilitators and barriers to implementing this content into medical education. And I think kind of if you think about this from this perspective up here, where you have this wheel where it's considering adoption by healthcare providers, I think if we have to think about it, we should also think about it from the perspective of adoption by medical educators, adoption by students and or health house officers as well. So this is what I see as important next steps. I see it's important for us to start to look at our curricula, the medical school curriculum, very closely. Again, knowing that this won't be a one-size-fits-all, but looking closely at our curriculum and starting to reprioritize things. I'm happy to talk more about that. I have some opinions that some may consider radical, which is okay, but this is going to require reprioritization, and it's going to require some hard conversations, in my opinion, right? And then identifying champions. I'm super excited about the work that Dr. Sheffield is doing, so she'll talk about that. When it comes to champions and forming some committees or work groups, engaging stakeholders, starting to talk to those lawyers, those ethicists, et cetera, about what we want to do here. And then also reviewing and considering admissions processes, thinking to the future about what admissions and or the match will look like when it comes to the learners that we'll have here at our university, and faculty development will also be key and important. And that's something that I've really been thinking about and wrestling with when it comes to how we are able to develop all of our faculty so that they'll be able to start teaching this content. And then take-home points, it's here. I think all of us know that now. There were some of us who were saying it's here, maybe a little earlier, but I think we all can agree now that it's here and it's going to continue to march forward with or without clinicians. I have here that it has the potential to transform the way that medicine is practiced and taught. I think it is transforming the way that medicine is practiced and taught. And then I think currently instruction for AI in medical education is lacking. We have to consider how we reprioritize our curricula. And then physicians, I'm going to say specifically clinicians, healthcare providers, so important that they are vocal stakeholders when it comes to implementation of this technology into medicine. So that is all I have for my part of the presentation. Now, thank you. I want to introduce Ben Lee, who I told him that I was going to say that he is a superstar because I believe that is true. Ben is great human being, and I've had the pleasure of working with Ben for the last couple years or so. Ben's a student in the integrated MD PhD program here at Michigan. While he was an undergrad at Michigan, he studied neuroscience and computer science, and he spent 2 years doing machine learning research before starting medical school. And during the acute phase of the pandemic, he also helped to develop a pandemic curriculum for medical students. And more recently, he's contributed to the Data MD and the AMA learning modules that I described earlier. And Ben is going to now come up and talk about AI, ML, in medical education from the perspective of a student.
Ben, yes, use the lapel for the recording.
Oh, great.
Okay, yeah. Good. Let's see here. All right, how's that? Is that good?
Yeah, we're good.
All right, great. Well, thank you so much for that introduction, Dr. James. First, I want to look out in the room, and I want to say a big thank you to invite me here. And also just say what an honor it is for me to be speaking alongside so many professors all of whom have taught me so much. As Dr. James said, I'm still a student. I'm currently doing my PhD in computational medicine and bioinformatics before I return to medical school in a couple of years. I was very fortunate to work with Dr. James and a multidisciplinary team on the Data MD and American Medical Association modules so early in my medical education. Working on those modules exposed me to the many considerations and careful balancing of priorities when introducing AI and ML into the medical curriculum, where there's already so much needed to learn in a finite amount of time. It also reinforced to me that AI and ML in healthcare are here to stay, and physicians must be active and vocal stakeholders to ensure these technologies benefit patients and providers in healthcare systems and learners. Today, I also wanted to share a bit about my experiences and perspectives as a student currently working in the AI space. And that's not to say that I've had a typical experience, but hopefully it can give some additional perspectives, especially for the students here in the room. I wanted to start this story in college, where I majored in neuroscience because I was interested in how neurons worked. I was intrigued by philosophy of mind. I also knew that it would cover a lot of my pre-med requirements. I had done some shadowing. I knew that down the line, I was interested in clinical medicine. I actually was about to graduate a year early and then apply to medical school. But that summer, Google DeepMind released their AI program called AlphaGo, which some of you may have heard of. It achieved superhuman performance on a very complex board game. This was called Go. And importantly, this was a feat that nobody thought was going to happen for many more decades. And this was very cool, but of course, I was interested in how AI could augment the future of healthcare. Which is a topic that many have been working on for decades now. So I decided to lean into that. I enrolled in the Michigan's College of Engineering, taught myself how to code, and ultimately finished a minor in computer science with a focus on machine learning, which is just a sentence now, but was difficult and still quite atypical at the time. And through those experiences, I found there were a lot of challenges to learning a new topic like AI. First, at present, there are few structured educational programs that smoothly integrate the requisite knowledge for a biological major like neuroscience and a computational one like computer science and engineering, right? Second, not every institution has the resources and world-class departments like Michigan does to make a story like mine even possible. Many times along the way, I was able to discuss my plans with advisors and mentors, and I feel very fortunate that that was my case. And third, a lot of great learning is done peer-to-peer. Something I realized when I switched over to learning how to code was I also watched a lot of my friends graduate and enter medical school and continue along their educational paths. Meanwhile, I was introduced to a new department, new ways of thinking. I grew together with this community and I built strong relationships, but this was still a pretty big change. So taken together, this was all a pretty hard and somewhat convoluted process. And when I got to medical school and my classmates asked me, how do I learn about AI? Whether they should all go learn how to code, I could honestly say, no, I don't think that's the right thing to do for everyone, especially when the med school analogy of drinking from a fire hose was abundantly true by a few weeks in. In fact, one of the best parts of working on the Data MD team for me was being able to learn from world experts about all the different considerations of AI in medicine, including the ethics, the pedagogy, and the real-life clinical use cases. And it became clear to me that the future of AI in medicine will require expertise from many perspectives, all coming together for a common goal. And this in turn will require substantial effort and resources dedicated towards reimagining AI as a fundamental tool set in medical education. Although I'm still a medical student, I've completed my first 2 years of the Michigan Medical School curriculum, and I noticed that there are many opportunities to smoothly integrate AI into existing undergraduate medical curricula, and this relates back to that first challenge I encountered when first learning AI. For example, many concepts in AI build upon evidence-based medicine concepts, which are already taught in our first 2 years, providing a natural setting to introduce foundational knowledge. In addition, there are many opportunities for vertical or longitudinal integration where pre-clerkship sessions on chest x-ray interpretation can be followed up by clerkship training of AI-enabled image analysis tools in radiology and other fields. And I think Michigan is particularly poised to do this with their trunk and branches model of undergraduate medical education. Secondly, like Dr. James mentioned, new medical education partners will also be important. By collaborating with professors in computer science, data science, law, and other fields, students can gain perspectives from each of these fields. In addition, there are many opportunities to work on multidisciplinary projects with students from other programs, and these already exist through organizations like Sling Health and the Center for Entrepreneurship's Generative AI Challenge. Of course, more is needed. Third, and as far as peer-to-peer learning, I've always enjoyed Michigan's collaborative learning environment, which itself stems from conscious educational design choices. This environment constantly reminds me of how far humility and keeping an open mind can go. Some examples are the AI in Medicine Medical Student Club and Michigan AI Safety Initiative, both of which were founded in the past year. And by supporting efforts like these, it will be more natural to recruit students trained and interested in this space going forward. So to wrap up my story, I just wanted to remain cognizant of the huge amount of work and modules our learners are already doing. By emphasizing AI as a fundamental tool set, it will make it easier to integrate learning naturally and intuitively into our existing curricula. But there will still be a lot of hard work needed to do at many levels to review the curriculum, identify champions, and support pilot studies. Nonetheless, from a student's perspective, my advice at this dawn of the generative AI age is to continue engaging with the technology and don't be afraid to find your own path. That's it for me. I have the great pleasure to introduce Dr. Sheffield. Dr. Ginny Sheffield is a clinical assistant professor in internal medicine at the University of Michigan and an associate program director of the IM residency program with a focus on DEIJ. She is a graduate of the Medical School and is passionate about creating equitable spaces in academic medicine. She is also co-chairing the UMMS task force investigating the potential impacts of generative AI in undergraduate medical education. I was very fortunate to be on Dr. Ginny Sheffield's inpatient medicine team, and I still use her lessons to this day. So with no further ado, Dr. Ginny Sheffield.
Is that okay? Can you hear me? Yeah. Awesome. Thank you so much, future Dr. Lee and Dr. James, for your really excellent words of wisdom. I honestly can tell you that I do not feel like I belong here in this space. I am not an AI expert. I am not a computer scientist. I do not have a PhD, but I am involved in AI work at the medical school, thanks to Dean Monrad, who I think it was just in passing, we were working on something else and we both agreed it's an interesting, important topic and something needs to be done. And so that's how I got where I am now. So I knew that I didn't know much about AI, generative AI, machine learning, and then I got in a room with a bunch of people who did, and that's when I truly understood the depth of my ignorance, right? There is so much to know in this space that it's overwhelming to think about. I see a number of people in the room who are on the task force. I'll briefly talk about what we did with the task force, and then I'll talk about some of the unique challenges that AI, is it not high enough?
Take care of that for you.
See, technology, not my friend.
You're fine. Yeah, ropes aren't your friend right now. So. Let's see if I can do this. Your sweater on that side.
How's that? Oh yeah, that's much louder. So for those who didn't hear, all I've said so far is that I don't know anything, but I am somehow in charge of things and people who do know many things. So what we've done at the medical school is taken on this challenge by thinking about it in a way of getting all the right stakeholders in the room to talk about it. We've had a pretty short timeline where our first step in the goal is figuring out what are our guiding principles. Right? Dr. James mentioned this. AI is going to transform medical education. So when we're making these changes, what's the North Star? What's the guiding light that we turn to when we make decisions about big changes? And so over the course of several months, we have together a team of 20-ish people from across the institution, students, MD, PhD students, former deans, folks from the assessment office, researchers, and we have come together about monthly to kind of talk about what are our guiding principles. And that's where I've learned most of what I know so far here today. Taking a step back and talking about this as clinical faculty, AI is incredibly overwhelming, right? So in medical education, we historically have not been very good at changing, right? We have a hierarchical structure, we have a way that we've done things, and it's usually pretty slow to get those things changed. It's over years, decades even, that we see these changes. And right now what we're seeing is the technology is changing over hours, over days. And so our ability to quickly adapt to that is tough. And a lot of faculty feel it really tough as well. Because yes, Dr. James is right. This is going to transform everything, right? It has the potential, and in fact is transforming clinical medicine, is transforming medical education. But what am I doing? I'm scrambling to finish my notes. I'm way behind in my emails, and I have to pick up my kid in an hour. So how am I supposed to learn the tools to an entirely new technology that's going to change everything when I don't even have time to finish my clinical notes before 10 p.m., right? Primary care doctors are going home and charting. So when are they supposed to learn these new skills? So that's one of the things that I think is the most challenging and overwhelming about this transformative change in medical education and medicine as a whole. I have had the opportunity to talk to a few groups of faculty, and I can say that they are not ahead of the curve on this. Most faculty barely use AI, if at all, that I've talked to. Obviously, they're the outliers. And most faculty feel, at best, cautiously optimistic, but totally overwhelmed. And so that is what this challenge that we have from a lens of faculty development. It's easy, relatively, to think about changing medical curriculum, right? Because we have a structure, we have students who are coming in and out of a classroom. But how do you do that for faculty? I don't go to a classroom. There's no one in charge of my learning, so it has to be independent learning. And when does that happen? In free time. And when does that happen? Non-existent for most faculty in academic medicine. Free time is not something that many of us have. And so there's a lot of apprehension, confusion, and a lot of people just really don't know where to start. When I have had the opportunity to talk to what I call the lay faculty, not the experts, about how they're using AI, the majority say, not really, or I've just played around with it. Some have been using it for, right, editing papers, manuscripts that they're writing, changing language a bit, or writing letters of recommendation. But that's the extent of it. And we know that's just the shallow end of the water of where AI could be used, could be leveraged to create that free time for faculty. And so that's one of the biggest challenges in faculty development is A, how do you get faculty in a room to be developed? B, what are the skills they need to know? There are experts who are writing these things up. And C, how do you make sure that they know it in a way that they're going to help students in their education and not get more muddled and confused? I think the other challenge that I've heard from a lot of faculty is historically medical education, like I need to know that you know what you need to know, right? I need to test your knowledge because knowledge acquisition is the goal. It's easy for me to give you a test. What do you know? Oh, you knew 70% of the answer to that question. But the entire paradigm is shifting. If we have these really, really excellent tools that can help augment, assist us in our clinical decision making, we don't need to memorize all those facts anymore. How do I assess someone on their empathy? How do I assess someone on their communication skills when I can't be in the room with them all the time? So it also shifts the way that we teach and assess students. And it's really important. I think it's hugely important that we can now recruit students from different backgrounds with a different skill set, but figuring out how you identify them, that's yet to be seen, right? We know that the MCAT is a number that's been used historically by med schools to say who are the good students. But now if we don't need to memorize all those things, how do we even recruit students? And then how do we educate them and assess them? And so kind of in summary, this is an incredibly overwhelming and deeply uncomfortable space for faculty, right? What are the things that I don't want to be as a doctor and as a teacher? Ignorant, right? But that's how we feel. And we've been trained our whole lives that you're supposed to know everything and do everything. And now we're in this space where our learners, the future Dr. Lee, who I'm supposed to be educating, knows infinitely more about machine learning and computer science than I do or ever will. And so how do we take this and learn from the people who are going to know more than us without totally becoming overwhelmed and insecure in our ability to function? So that being said, I'm still incredibly excited to learn more. I am actively trying to, but I still know nothing. And it's a deeply uncomfortable space that we really have to think thoughtfully about how do we educate, train faculty so that they can assist the learners coming up with these new tools. And I'll hand it back to Dr. Hurwitz to introduce our next speaker.
Well, thank you, Cornelius, Ben, Jenny, those fascinating thoughts. Our next speaker is Dr. James Woolliscroft. Dr. Woolliscroft received his BS and his MD from the University of Minnesota, the other U of M. He completed his internal medicine residency at the University of Michigan and joined the faculty in the Department of Internal Medicine in 1980. He's an emeritus professor in the departments of internal medicine and learning health sciences. His scholarly focus has been on medical education and has resulted in numerous publications, invited presentations, and visiting professorships across the U.S. and internationally as well. Dr. Woolliscroft has served as the chair of the Association of American Medical Colleges Group on Educational Affairs, chair of the AAMC Research and Medical Education Committee, and as a founding member and president of the Clerkship Directors of Internal Medicine. He has also served on several national boards of medical examiners committees and the Liaison Committee for Medical Education Board. At the University of Michigan, he has held various administrative roles, including Associate Chair in the Department of Internal Medicine, Chief of Staff at the University of Michigan Hospitals, Associate Dean and Director of Graduate Medical Education, and the Executive Associate Dean. And then from 2006 to 2015, Dr. Woolliscroft served as the Dean of the University of Michigan Medical School. He's received multiple recognitions, including selection as the first Josiah Macy Jr. Professor of Medical Education, an endowed professorship awarded through a national competition, being named the Lyle C. Roll Professor of Medicine, receiving the Society of General Internal Medicine's Career Achievement in Medical Education Award, and the AAMC's Group on Educational Affairs Merrill Flair Award. The University of Minnesota Medical School presented him as their Distinguished Alumni Award, and the University of Michigan Department of Internal Medicine honored him with the Paul D. Kruif Lifetime Achievement Award. In 2014, he received the AAMC's most prestigious recognition, the Abraham Flexer Award for Distinguished Service to Medical Education. He's a master of the American College of Physicians and was selected as a laureate of the Michigan chapter. He's a fellow of the Royal College of Physicians in UK and an elected member of the National Academy of Medicine and the United States National Academy of Science. He's also the dean who was serving when I became department chair back in 2006, and I can tell you he's a wonderful leader and a fantastic mentor. Dr. Woolliscroft.
Thank you, Ed. And thank you for not following through and telling some very embarrassing stories as you had said you might do. Well, it's a real pleasure to be here. You've heard some great perspectives and talks. What I'd like to do is something a little bit different. So Cornelius started out with a very realistic case for right now. But what I want you to do is to think about 2050. Because the medical students that are just starting now will be in the midst of their professional careers in 2050, in 25 years, essentially, from now. So if you're a patient, what would you want that to look like entering into the clinical care system in mid-century? Would it be like it is now? My wife and I, making appointments for literally a year out from now because everything is so congested? Using the portal because it's impossible to get in to see a physician, and that's fairly truncated? Is that optimal? Having care constrained by outside entities that tell you what you can and can't do as a patient as well as a physician? Why do I have you think about that? Because in medical education, I would say that the end goal should be the beginning for what we engage our medical students and learners in. If we don't know where we're going, we'll just continue exactly the way we are now, with minor little changes like Dr. Sheffield said. And interestingly, going to the Flexner report that Dr. James mentioned, yes, that came out in 1910, and that was looked at as a watershed moment. Interestingly, the University of Michigan was one of 5 or 6 schools that were highlighted in that report as doing what all medical schools should do, which is to train their students to practice scientific medicine. Because if you think back, so the University of Michigan Medical School started in 1848 or 1850. By 1869, it had, because of a very small number of faculty, put in place a very far forward-thinking curriculum based on, quote, science. And what was science back then? Well, the cell theory was just being developed. The whole idea of infectious diseases was just being developed. Why? Because of incredible advances in technology, in optics, the microscope allowing people to see things they had never seen before, in chemistry, the whole idea of biochemistry. All these things that we take for granted were revolutionary back then and actually were derided by the medical establishment as being essentially irrelevant to the future physicians. Well, we know what's happened. We know what's happened over the last 100+ years and all the advances that have been made. And I agree with Cornelius that AIML and all of the derivatives are not only going to be transformative, they're going to be disruptive. And I can even foresee that just like the Flexner report led to about 200 medical schools being closed, if medical schools don't change and prepare their graduates for this new world, they too will be totally irrelevant. So let's think about what that new world might look like. So I was a general internist, just like Jenny, just like Cornelius, and found it oftentimes very frustrating. I would have an incredibly full clinic of people that honestly didn't need to see me. It was great to see them. I enjoyed the camaraderie, all of that sort of stuff, but they had hypertension, they had congestive heart failure, they had pulmonary problems, and they were well controlled. Some of them liked coming in to see me, probably some of them didn't. Those that were working, it was an inconvenience, but that's how we did things. Let's think about 2050. So essentially all hands were raised when it came to smartwatch, smartphone, etc. So I could imagine being an adult doctor. No longer will internal medicine or primary care be relevant as labels, but an adult doctor that has a cohort of individuals who are relatively stable being monitored through sensors on a real-time basis, not like what I dealt with when somebody would come in for their hypertension checkup and you'd get a spot in time, which you had no idea whether that related to what they were doing throughout their workday, the rest of their life. Even the most compulsive of engineers, it was just snapshots. And we overtreated and we undertreated. And that's the same thing for so many things, but think about in the future. Even now they've got rings that can monitor your blood pressure, your PO2, your oxygenation. Your walking, if you've got Parkinson's, helping to do the drugging intervals due to the sensors that are in your shoes that can pick up when your gait changes. Depression, when your voice, your rhythm of speech changes. And the list goes on and on and on. So I can imagine as an adult doctor, no longer will I be tied down to this schedule seeing people that were slotted in 6 months earlier and may not actually need to see me, but be available for those that truly need to see me. So what's that mean for our students? Excuse me. What does that mean for our faculty? As Dr. Sheffield said, the potential of AIML is exceedingly concerning for many in the academy, certainly in academic medicine. Cornelius did that deal with the prostate. Already, there are FDA, not only cleared, but in use, looking at screening mammograms, looking at screening lung CTs. We have here at the U AI-enabled colonoscopy viewing. The list goes on and on. The question is, then why do you really need a doc? Looking at that mammogram, looking at that lung CT, looking even at that colonoscopy, because robotic advances will be that, do you really need a doc trained to do that? Maybe you just need a technician. Sorry, Akbar. Maybe you don't need many of our current professions. So what do we need? It's very important that we look at what are the immutables about being a physician. And being a physician isn't about a technique. It's that human-human interaction. Because talking to a lot of people, lay and professional, very few people want to be told they have a life-threatening condition by a computer or through the portal or something like that. Very few people that have a chronic life-altering condition, rheumatoid arthritis, whatever it might be, don't want to have some continuity of relationship. So the communication, the empathy, the human-to-human, the professional, the ethical things, those are some of the immutables that we need to think about. It's not necessarily knowing the Krebs cycle, even though I learned it and forgot it 4 different times. So how are we going to change medical education? How are we going to change learning? Let me go off on just a little tangent. In 2011, National Academy of Medicine, it was IOM back then, had a group that looked at the charge to change the taxonomy for clinical conditions. You know, right now, like I was talking with Ben just briefly a little bit before we started, he's looking at diabetes. So how many types of diabetes are there? Anybody? 2. Anybody have a different estimate? Over 50. And so very different mechanisms that we all call the same thing. Why do we call it that? Because the glucose is raised. Why do we call it diabetes? Because back in the 1900s, even before that, when people could taste the urine and tell, that's what medical students had to do back in the 1800s, that it had a high sugar content. And then we could actually measure it with biochemistry. And so we knew people had diabetes. Well, now we've got all these other things. We've got genes, we've got proteomics, we've got environmental things, all of which lead to different mechanisms with the same result, but we haven't changed our taxonomy. It's the same thing for cancer. It's very confusing. You know, why do we teach histology even though a good friend of mine is a great histology teacher? It's not important what it looks like. It's important about the cell surface markers and what's going on intracellular, because that's the mechanisms whereby we might make a difference going forward. So the change for the faculty is going to be incredible. The change for the students will be incredible. What we emphasize, we can't even begin to but imagine at this point. But it's incredibly exciting to a guy like me who can sit in his rocking chair and confabulate about what the future will be, and then have incredibly gifted people actually doing it and thinking about it. But we need to be looking forward. And many of you, I would charge you, have to create this future. Because if we're not involved in creating it as learners, as faculty, as lay people, others will create it for us. One of the things that I found very interesting, how many of you have ever listened to Lex Friedberg, I think it is, his podcast? Anyhow, in September he had one with Mark Zuckerberg with photorealistic avatars. Zuckerberg was in Silicon Valley, Lex was in Austin, and this is a whole new type of avatar that has the most minute changes visible on it. I would encourage you to look at it. It's podcast number 398. It opens up a whole different reality for distance-based communication with patients. Distance-based communication, asynchronous in time and space with students. I would say the focus that we've talked about of precision education is possible with data analytics, with AI-generated content, with the avatars that are available. We can create that. Michigan was a leader back in the 1800s in the implementation of science-based curricula. I would say that Michigan is in a great place to help lead this revolution. And it will be a revolution, and there will be a lot of bumps in the road, and there will be a lot of pushbacks. Because bluntly, a lot of power bases and a lot of money are at risk here. But I think it's something that we need to do for our future patients and society at large, not just here in the US, but globally. So with that, I will stop my little stump speech, but really would like Ginny and Cornelius and Ben to come on up here. And I want now to open it up to all of you for questions and comments once they have their spot up here. We can pass this one around.
This one's on.
Okay,
This one's
yes,
on, right?
Sir. Oh, okay, there we go.
Yes, you mentioned what's needed in medicine. I just want to say that possibly what's most needed is truly personalized medicine, not just including both genetics, family history, diet, lifestyle, because you mentioned there are 50 types of diabetes, but actually each case is an individual case. So the extent to which one can tweak the treatment to match the individual, that would be one of the true benefits of AI. Thank you.
You're right on target there, and actually that was that 2011 Institute of Medicine report that we needed all of the omics as part of it, that if we're ever going to truly move forward with precision medicine, it's not just genetics. That's just a little piece of it. It's the environment people grew up in. We know that influences in childhood, social, emotional, physical, can have manifestations in disease decades later, epigenetic changes that are intergenerational, all of these things. And so we now have the ability to actually do that, which is going to be revolutionary. Any other?
Thank you for the question. I just wanted to add a few things. So I work on multi-omics research, and one of the things in that field are personalized risk scores. And just to kind of go back to one of Dr. Woolliscroft's points about how we'll have all these emerging technologies, and these will become part of practice in a few years, 10 years, 20 years, depending on the technologies. But I think being able to communicate those personalized risk scores to patients in a way that is both informative and does justice to the science, but also shows your humanity, that's going to be a major thing to train clinicians in as well.
Other questions or comments? In the back there?
I wanted to first off thank you guys for the presentation and the speeches. It was really enlightening as a undergrad that's on the pre-medicine path. I was wondering, like in modern day medicine, when you're in the operating room, like there's like striker representatives who are telling the surgeon like how their specific new little tool works, and they don't necessarily have that education beforehand. Do you see like a kind of transitional, like a transition period where there's someone that's really well-versed in AI that's kind of in charge of all the AI for physicians and telling them and letting them know like what ChatGPT says and things like that?
That's a great question, and I'm going to just kind of add something to what you just said. Another one of those things that I've been thinking about. There was a really interesting paper published in Nature Medicine, and it described direct-to-consumer AI, basically. So that's basically artificial intelligence that's health-related or that's supposed to impact or influence health decisions that consumers can purchase without a prescription from a physician. And that led me to kind of think about what our patients are dealing with or facing out there when it comes to those types of advertisements from companies that are designed, or they have experts who are trying to get them to use their product. So that's just another one of those things that we as physicians have to be aware of. It's not all that different from some of the things that we're dealing with when it comes to patients having access to various things that can impact their health, but it's something that we definitely need to think about. But specifically to your question, governance, that sounds like a governance or a regulation question. And here at Michigan, again, we are very, very fortunate in that we have great infrastructure. Karandeep Singh, who was on our team, and he's now headed out to UCSD, he was basically responsible for kind of looking at any technology that was implemented at the University of Michigan. Unfortunately, not every institution has that kind of governance structure in place, but at a local level, it's very helpful to have that kind of leadership. But even on a national level, when it comes to the FDA, many of those direct-to-consumer apps and or models, many of them are not regulated by the FDA. And I'll be quite honest with you and say they're still trying to figure out what they should and what they shouldn't be regulating. They only recently decided, at least from my understanding, that AI implemented into the EHR. And Akbar, please correct me if I'm wrong, but that's something that they're going to start to regulate as well. So they're still very much in a evolutionary state as well. But the point that you bring up related to governance is super important.
I'll just add something small. I think that Dr. James and Dr. Woolliscroft mentioned this, but one fear that I have in reflecting on your question is that it will be non-clinicians, non-physicians who are showing physicians or marketing AI tools for physicians, like in the case of in the OR. I think the risk of that is that, right, they don't have the experience to fully understand the role of a physician. Right, if you've never been in the room and told someone that they're dying, like you can't get that experience from, right, marketing and all this other things. So I think I am incredibly grateful for the folks from within who are taking this on, and I'm really hopeful that it's people like future Dr. Lee and Dr. James who are helping to guide us in these decisions rather than external parties that are coming who don't have the clinical experience.
I just wanted to really quickly say, too, I kind of liken it to big pharma, right? You often hear about like big pharma, and in the past there was an issue where you would have drug companies that would come into clinician practices and try to say, hey, I'll give you a sample, or you can use this or use that. I think we're going to have to be, things are evolving, and I'm not saying it's going to be the same thing, but I'm sure you've also heard of big data, right, or big tech and so on. So I think we're going to have to just kind of be careful and use some of those ethical principles that we kind of rest on and kind of adapt them to some of the things that we're dealing with when it comes to AI and ML in healthcare.
And one of the reasons why what Dr. James mentioned with Karandeep Singh and the governance we have here that's so important, a very well-known case example, if you will, is facial recognition and the bias that has inherently had in a number of programs. Unfortunately, too infrequently have AI, like the sepsis model, been externally validated in the institution that is implementing them. And so that just has to happen almost regardless if there's a national clearing, because the population of patients that are being seen in, say, I don't know, bad acts might be very different than those that are being seen in Dallas, Texas. And having an algorithm that was developed in bad acts may have very little appropriate relevance to Dallas. And so these things have to be looked at very carefully. That's why what Dr. James is trying to do, educate at a certain level our medical students and learners as to fundamentals, just like with evidence-based medicine, evidence-based algorithmic assessment before applying it to your patients. That's why that's so important. So you bring up a great, great point.
Yeah, I just wanted to add to that. There's multiple levels of governance, right? So we talk about internationally, like the WHO has put out some literature or a report related to governance of AI. Certainly the White House report recently released in like October of 2023. But at the individual clinician level, that, as Jim stated, that's one of the things that I'm kind of thinking about, because I'm thinking about a clinician. I'll give you an example. I have a friend and colleague that started using an AI-based technology, and it was developed by Mayo and in partnership with another company. And you hear Mayo, and that's great, right? It sounds like a great institution, a certain company, and they've began to implement that independently of any governance from our university. But you kind of question, are you aware, or because it actually provides a diagnosis, right? The technology that I'm thinking about that this person was using, you take that and you apply that in your clinical practice. Well, was that technology trained on data that was representative of your patient population, and can you apply that in your clinical setting? Are those the types of questions that we're asking prior to beginning to use these technologies? And that's why I think at the individual clinician level, it's important to have that governance in place as well.
Hi, I'm Van Harrison. Only the older people on the panel know me. One of the questions that I have implicit in what each of you has said is the context. You've been talking about medical education as though it had unique power to leap forward by itself, while the teaching institution, over half of the physicians in the country are now employees of organizations, is how fast the education in AI going to be meaningfully incorporated, really governed by how quickly University of Michigan Health, talking locally, and our institutions nationally make the practical application of it available in a systematic way for students to learn from clinicians who are being working within those new systems. That is to what extent is medical education the cart or the horse in terms of this change?
Thank you for the question. I put a comment up there that said AI is going to move forward regardless of what clinicians do. I very much believe that's true. People are going to develop algorithms, good or bad, regardless of what we do in clinical practice or in medical education. My concern is, again, I kind of know the history of evidence-based medicine. My concern is that we reach a point where it's flooded, and some could kind of argue that it is kind of to that extent, or it is kind of there. But my concern is that we start to see these models in practice that are just, it's kind of a wild, wild west, so to speak, with people using these technologies in their practice, and then we're trying to kind of play catch up. My hope is that places like the University of Michigan, and there are other great places out there, Duke, and that are doing great work even from a medical education perspective. My hope is that we can kind of get out ahead of things. I'll be honest and say, Jim and I started this work back in 2020, 2021, and we're like 3 or 4 years out, right? And so, we were trying to kind of get ahead of things at that point, and the NAM, thankfully, was supportive of what we were trying to do, very forward-thinking organization, but we've still got a long way to go. So the hope is that, yes, in medical education, we're not anticipating that we're going to kind of change what, I'm hoping that we will influence what developers do because they know what we're teaching our students. So therefore, that perhaps leads to more rigorous development of models. But I'm not super optimistic that we're going to have a major impact on whether or not they, how they develop algorithms, and then, whether or not they're implemented into clinical practice.
So that's a very important question, Van. Academic medical centers might not be the leaders. What do I mean by that? There are a lot of areas that are underserved in this nation. Rural areas, we oftentimes think of inner cities, but actually the rural are if you will, worse off than the inner cities. And we live in a suburban paradise in contrast to a lot of those areas. Why is that important? Well, already there is the retinal scan interpretable by an AI algorithm for who needs to see a specialist in retinal ophthalmology because their diabetic retinopathy is progressing. And that can be out in the rural areas where there are none of these specialists. Already, there is a real push for mental health and behavioral change services to be based on actually avatars, even though they're relatively primitive, in all of these areas that don't have access to behavioral or psychological or psychiatric services. Just as we have become totally dependent upon the reading from the EKG machine rather than every doc interpreting the EKG, there are now services that will read X-rays in these small hospitals so they don't have to wait for the radiologist the next day or 2 days later to read them. They'll be overread, quote unquote, for billing purposes, but the data that will be used for diagnostic and treatment was available through the algorithm. So what am I saying? These situations might actually lead our trainees to be exposed to real-time important AI, ML applications that aren't because of the necessity being implemented in places like this. So it might actually be these types of systems that lead us. And that's why potentially in under-resourced areas, here or internationally, we will see adaptations and implementation of some of these programs before we do in a place like Michigan Medicine.
I'll just add a quick story. So I mentor a high school student, and he's interested in AI. And as a medical student, not necessarily a physician, I still can give him some advice. And AI almost virtually wasn't a thing when I was in high school, and coding and machine learning concepts. And he has probably more depth of knowledge than I do. But having a hand on that wheel in terms of education and then in terms of what he's thinking about and what he's developing, I think can add a lot of value to his project. And as Dr. Woolliscroft says, I mean, a lot of these innovations will come from places outside of medicine, but to be involved and for me to learn and to be on this panel, it's good to soak that in and then almost, figuratively to have a hand on the wheel. So that's kind of how I think about it.
So to your question of whether medical education institutions will be the cart or the horse, I think the horse. To put it simply, I can take my work in another space of diversity, equity, inclusion, and justice in medicine, and we've seen a lot of things that haven't changed over time, a lot of racist practices that haven't changed over time, over years and years. And where is that change coming from? To the greatest extent, it's coming from the students. It's coming from folks who have had their whole lives preparing for this because they've been learning in a different way than the people who perhaps have been practicing for 20, 30, 40 years. And so it has to be that we are empowering the students to have the tools they need to question these tools, to develop these tools, and to adjust these tools so that they're the right fit for real patient care. And so in my opinion, one of the jobs is to just give them the tools so that they can appraise them, and then the change will come from, it'll come from the students, in my opinion. I think there's a few experts who are in faculty, but the folks coming up know a lot more than most of us.
I think that's a great point that Jenny makes. I will emphasize, I do think, industry academia partnerships will be very important as we develop various tools. At the same time, though, I think there are the realities of culture within academic institutions. I've had conversations with one individual who said, yeah, U of M is so collaborative, it's great, but if you look at other institutions, perhaps out west, I won't say any specific names, but they tend to, the person that I spoke to who's an expert in this space said there tends to be kind of kingdoms within certain areas, which kind of silos everyone off so that they're not collaborating or working with one another in an effective way. But I think the reality of culture within large academic institutions, at least in my opinion, it's really important to think about. And while things can kind of be held up because of culture within large academic institutions, non-academic institutions are often moving forward and moving fast. You've probably heard of that saying, fail fast, right? That's pretty much what they are doing. So I do think that we can certainly be leading, but I think the question is like leading with what when it comes to AI, ML, and healthcare. I think there's a lot of great things that are being done by non-academic institutions. But again, they're often moving a bit faster than we are for various reasons.
Thank you guys for speaking today. My name is Phil Barrison. I'm an MD PhD student in the Department of Learning Health Sciences. And jumping off Dr. James' point about culture, we're right now not only currently in a climate of rapidly evolving culture in medical education, but across society when it comes to AI and ML. From the perspective of the minds in this room, there's clearly a degree of techno-optimism about AI and machine learning and its potential in healthcare. As we think about developing educational curriculum, both for medical students as well as other health professions in this evolving climate, how do we make sure that we are not running away by making assumptions about what is actually needed for AI and ML in healthcare? Assumptions that may not align with the lived experiences of both providers actually in the field, but also what patients expect from their care. Thank you.
That is a wonderful question. So when we initially sat down to kind of think about what learners need to know, we tried to keep it as foundational as we possibly could. We sat down and we looked at learning objectives, potential competencies, and so on. And we thought at baseline, again, going back to my point related to not every clinician will need to know how to develop an AI model. There's something called Bloom's taxonomy that we as medical educators often think about. And you think about, those people out there who are creating, models. Certainly we need those physicians out there as well. But we were kind of thinking about the baseline everyday clinician. What are some foundational principles that we can kind of start with, and then we'll build upon as we see how things kind of evolve. So that's kind of the approach that we took, knowing that things are going to evolve, knowing that things are moving very rapidly in this space, but we tried to take a very foundational approach to things.
Really quickly, my answer will be similar to prior. How do we make sure with people like you who are asking thoughtful questions like that and are studying this, these issues to kind of help to make these changes within the system, from within the system?
Hello. Yes. Super quick, 1:30. One of the things that I've observed sometimes is rapid changes that need to happen in the educational system, similar to what Van was saying, can be limited by the presence of the experiences in the clinical environment, and then more specifically, guidelines and regulations or requirements external to the educational programs. Currently, to become a physician, to be licensed to practice as a physician, there still remains the requirement to pass multiple choice question tests to become licensed. How does this group see the assessment of the future physician to become a practicing physician needs to evolve to support the clinician of the future who is not going to be the person who regurgitates facts on a test, but is doing the things that are supported by AI.
Way to finish with an easy one.
Time's up. No, clearly it'll have to change dramatically. And here actually, the whole idea of precision education, data analytics, so that Khan Maggio, I think it's called, the Khan Academy with their personalized tutor is a great example for a lot of what we could be doing in medical education. And then actually, maybe the rhetoric around competency-based education could be matched with the reality. And that's not based on MCQs and a 70% pass rate. It's based on performance, it's based on workplace, it's based upon embedded education. It's the Brian George approach in the surgical residency to assessing their competence and readiness for practice. It will have to change dramatically. This is one of those huge impediments because of the embedded structure that we deal with. But I'm glad you're worrying about it, Seetha.
Okay. Well, listen, this is a fantastic session. So let's say thank you to our discussants. Thank you so much. I think everybody really enjoyed it and learned quite a bit. And I hope you'll come back for our next session, which will be on Friday, March 15th, once again in person. It's a 3-hour session, a workshop, the LHS Collaboratory Special Workshop, Natural Language Processing for Health in the Era of Large Language Models, led by Dr. Vinod Vaidiswaran. So we'll see everybody there. And for this, please give us your evaluation. There's the QR codes to do that. And thank you, and everybody have a wonderful day.
That was a great job there, guys. I wish you well with doing diabetes.
Thank you, sir.
Nothing small.
Thank you for having me. Can we get a picture with all that?
Sure. So, unless you